no vacuoles, no DNA degradation, normal morphology, and no inequality, as I told you. So they are very good quality sperms, and they always give us better outcome. So highly renowned very good technique which we can use, and these dishes are available and we are using it very frequently. Second is that we when we carry out ICSI, we replace ICSI media with hyaluronone only. With PIXI, because the ICSI media which contains PVP, that may be harmful for these sperms. So we use a softer sperm immobilizer that is called hyaluronone, called sperm flow, available in the market. So we can replace PVP by hyaluronic acid. It's a very soft thing, natural thing, and it can select sperms better. Sperms which have got no damage are selected, and then that's the way we go about. Then multiple studies have been done, and they have found that both the methods are equivocal. We need more studies. Both are equivocal, though the sperm flow is more physiological. Then one more study came last year in 2009. It showed that HbA bound sperms have got better embryo quality and implantation rates. But I think more studies are required. I have used it myself many times, and I think it's got better outcome than routine ICSI. Then coming to any other techniques which we have, now look at other techniques. The new technique which is comes to your mind is something called IMSI. What is IMSI? IMSI is intracytoplasmic morphologically selected sperm injection. So here we are normally when we do an ICSI, we do sperm selection at around 3000 eggs. So sperms are selected, but we don't do a deep selection. But when we carry out IMSI, the magnification is very high, and we select the sperms which are of very, very good quality. We just dissect the head of the sperm, look for any vacuoles or any bodies or any DNA damage, pick up those good quality sperms and put them back, and we just pick them up with an ICSI needle and do an ICSI. So IMSI is intracytoplasmic morphologically selected sperm injection. We have till now heard about a term called ICSI. ICSI is intracytoplasmic sperm injection. Here it is a morphologically selected sperm injection. That's the only difference. In ICSI, we can't do that type of selection which we can do in IMSI. So how do we do that? So for sperm selection, we carry out a thing called MSOM. And MSOM is motile sperm organelle morphology examination, meaning the sperm is moving. Normally the sperm is moving. We're not able to identify the vacuoles in the DNA or the acrosome. But here, in this particular technique, what we can do is that in a moving sperm at a very, very high magnification, we can do all these sperms which are having minimal organelle morphology damage. Pick them up, that is called MSOM, and when we combine MSOM and ICSI, it becomes IMSI. So it is a real-time technique. It gives us a very good outcome, but here we have to use some sort of optics. The optics are called Nomarsky's optics, which we have to actually procure, and it's going to give the magnification of around 6,300 times. In ICSI, we normally work at 200 or 300. Here we have magnification of 6,300x. You can imagine how big the magnification is, and more accurate examination of the sperms can be done. Can be done here in case we do this particular technique. And the optics of Nomarsky, I've told you, we have to have a different sort of optics here, and we have to classify sperms as per MSOM. There's a classification. Just remember that when we do morphological sperm selection, here we always talk about, we say that in MSOM, we can select the sperms with no vacuoles at all. So this is the very good method of doing sperm selection where there is no vacuole at all. So this is a very good method as compared to simple morphology plating, which we do. And then we have different classes of sperm, 1, 2, 3, 4. So you just remember as a gynecologist or even as IVF doctor that we have to look at sperms which have got normal form and no vacuoles. Even a one vacuole can be a problem. So normally in case we go by WHO parameters, 2 vacuoles are allowed. In case we have one vacuole more than 20% of the area of the head, that is a problem. Or normally small vacuoles, 2 are allowed in an acrosomal region. But in here, it's got very strict criteria. They say not even one sperm can have single vacuole. So a vacuole can always, any sperm which has got a vacuole, that sperm may be having a DNA damage. There can be, sperm can be denatured. Large nuclear vacuoles means larger problems. So we have to select a sperm which has got no vacuole. Such a sperm will have minimal morphology damage, minimal morphological problems, minimal DNA damage, and they are the ones which we are looking for. So pick up these sperms and we get very good outcomes. As far as possible, in case we have a facility, we can always carry out MSOM and then we and carry out ICSI together. And the combination of MSOM, where we select morphologically normal sperms, and ICSI, it becomes IMSI, and it works at 6300x magnification. This is what you have to understand. This will give you better quality sperms, and in the real time situation, you can just pick up your sperms and do ICSI for them. So application of MC, they say that, okay, in case it is so good, why don't we carry out semen analysis with ICSI only, with MC only? Yes, you can do. We can have proper semen parameters, very good parameters we can obtain, but I don't believe that we should be doing semen analysis by MC, because this is a very expensive technique and this is not the right technique for carrying out semen analysis. Staining is pretty good for me to look at the DNA damage, but yes, when we have got multiple IVF failures or poor morphology less than 4%, then we can combine AMSOM and ICSI, and that is equal to MC, as I have told you before. The aim of my talk has been to tell you in very broad sense, what are things which are available to you, not to confuse you. We can talk about MC, we can talk about electrophoration or electrophoresis for long, long hours. But I just want to give you some basic idea that in cases who have got teratospermia, who have got very low sperm count, uh, or bad quality sperms, we can follow the embryo development on day 3, day 5, pregnancy, abortions, and it has been found repeatedly that we can, by selecting better sperms with MC, we have a better option of having ongoing pregnancy rate and having better implantation rate. So normal sperm size and shape can be selected by ICSI also. ICSI, which we all laboratories they do. MC, not many people do. It can be done by ICSI also, but MC adds to, as you can see, we can look at these small vacuoles in the head. I'm sure you can appreciate these small vacuoles here also. So when we have a vacuole, the outcome is bad. So you can just ignore the sperms with a vacuole, leave them out, pick up a good sperm and inject. That's it. So we found that these sperms which have, when you carry out ICSI or MC, on day 2, day 3, nothing much can be made out. But as we go towards later day 5 transfers, the chance of getting a blastocyst will become less in case we carry out ICSI only with MC. The chance of getting day 5 embryos become better. We get better pregnancy rate and better take-home baby rate. So MCs, whenever we have a poor quality sperm sample or morphology is bad, we can always go for MC. It works very well. But on the other hand, when we got a very small sample, then MC may not be possible. The sample is very bad, may not be possible. But overall, it's a wonderful technique to carry out MC for whenever we are suspecting high DNA fragmentation or a poor morphology on semen analysis or severe teratospermia. Yes, we can. But the only issue is that when the sample is very bad, like in teratospermia, you may not be able to pick up a good quality sperm because every sperm may look defective, but that's a matter of chance. So should we do MC for all? The verdict is that are there any indications not to try to select the best sperm? uh, but even if we get, even in any case, in case we are able to get a good quality sperm, we get a better quality embryo. So book says that, okay, we can do it for everybody. But here I would like to hold my guns. I say that do basic analysis first, do basic morphology first, do DNA fragmentation index first. In case you have any problem or patient is diabetic or some other problem, then only go to MC. Otherwise, don't go to an MC in every case. So this is additional tool to an ICSI which we have. It gives you better quality embryos, more capacity to implant. It gives you increased cumulative pregnancy rate, and we can define our classification of the sperms after we do this. So as I've told you, all indications I've told you already. It can be done in any patient, but it may not work give you good outcome in every patient because it is not a cost effective technique. So do it when we have very bad quality sample or poor fertilization failures and so on. So MC, we need change of optics, we need better equipment, we get better quality sperms, and it's an quite effective technique. So final conclusion that when we are trying to select best quality of eggs, why don't we select best quality of sperms? The time has come when you start thinking about sperms. That's the aim of having this talk, to make you think that sperm selection is possible. It may be by these techniques called electrophoresis, zeta potential, max, or IMSI. Some people also carry out birefringes. My favorite is using microfluidic slides. You can use them. Here we use a nascent sample and we get good quality sperms in one corner of the chamber within 5 or 10 minutes. There is no centrifugation required. These are the multiple methods available to us and they help us in doing better selection of the sperms. Well, thank you so much. I have ended my talk here. And as we had promised that we'll all take around 23 minutes, then we'll have all our queries in the end. Thank you so much for the patient hearing. And now with the permission of the organizers, should I move on to the next?
Yes. I want you to introduce.
Yes, I'll do that. I'll do that. So now we have with us Dr. Himanshu Bhaveshi, a very dear friend, and actually he doesn't need any introduction. And when you look at his bio data, it is mind blowing. He has been awarded the prestigious IMA award, excellence in the field of medicine. He has got the first childbirth of India with vitrified frozen oocytes. He wrote a beautiful book on IUI, the first book which I bought in my life, sir, when I joined IVF, was your book. And and I think it's out of print now, but that book is one book which everyone should buy. Then Sir has got a multiple units all over the country, IVF units, and I know. And then he's got published, he's got many thousands of IVF babies to his credits. He's got a wonderful centers in Gujarat, in Delhi, all over the country. He was the founder, president of INSTAR, that is Indian Society for Third Party Reproductive Technique. Thank you so much, sir, for joining us. And thank you so much, organizers, for giving me this permission to speak in front of the August audience.
Thank you very much, sir, for your time, Dr. Bhaveshi.
Yes, I have unshared my slides. Now you can start, sir.
Yeah, thank you. So, Dr. Bhaveshi, please share your slides.
Thank you so much, Dr. Talwar, for your wonderful introduction. It always is a pleasure. Okay, my internet connection is unstable. Can all okay?
Yes, sir, we can see your presentation.
Okay, thank you so much. So now COVID-19 and fertility. Why do we discuss COVID-19 and fertility? Basically, there are a lot many things to discuss when we think of COVID-19, but does fertility also require some discussion? The answer is really yes, because there is an impact of COVID-19 on everybody's life, and that impact is not simple. It's a pandemic and it has covered the whole world. We all know this picture and we know that these colors are changing every day and new cases are coming. More than 6-7 crores of people are affected, and also the cases, the numbers is increasing. That means the COVID is with us and COVID is likely to stay with us for a longer time. So it's not that it's easy to say that COVID is over or COVID will be over. Even if we get vaccination, I'm not sure that it is going to be available to each and every people in the world. So COVID appears to be lasting for a longer time. And if it is lasting for the longer time, what should we do? Should we start infertility treatment? And that is where I would like to say that what we thought was that we had a pre-COVID time. That means we were living in a time where we used to do what we normally practice as a routine infertility practice or routine ART practice. And now we've thought that, okay, the COVID will go away and then again we'll be in the post-COVID time But let me tell you, friends, that we are not going to have a post-COVID time. At least for reasonable period of time, it will be a with COVID time. And we have to adjust to this new normal, that we will be working in an environment where COVID will exist. It may not be as bad as it is today, but it may not be totally gone. Now, then, what is the situation? Like natural conception, if we talk about, it is not restricted, or no warning is issued against the natural conception by any of the bodies anywhere in the world. So that means the couples are conceiving naturally in this COVID time. Since the COVID has begun, lot many couples have conceived. On the contrary, there are infertility patients also. All of us have experienced that many of our long-standing infertility patients who were considering IVF also have conceived during this lockdown period because of the availability of the time, relations, whatever the other advantages it had. So nowhere in the world natural conception is restricted because of the COVID. So in that case, why are we worried about the infertility treatment? Then why should we consider it differently? When the initial phase of COVID was there, the biggest challenge was burden on the healthcare system. In India, by and large, infertility centers are standalone or separate centers, and the practice is in private sector more than in the public sector. Of course, it is there in public sector. Of course, it is there as a part of multi-specialty hospitals as well. So if the medical resources or the hospital resources were diverted to all other systems, probably it was not capable of coping up with the load of COVID patients. And that is where, to avoid the burden on the healthcare system, it was decided that all elective procedures should be temporarily abandoned. And we all abandoned, we stopped the cycles even in the middle of the treatment, and that caused a lot of problems to us, patient, and everybody. But then in that case, now what has happened is that so far as we talk of our country in India, we have hospitals which are COVID and non-COVID. So what we are thinking, or what we see now, is that the non-COVID hospitals are not creating burden on the COVID hospitals, and that is where the healthcare, extra burden on the healthcare system is not a valid argument in our situation. The second reason was the increased risk. Increased risk to whom? The healthcare providers and the patients. Now, healthcare providers we'll discuss later. But when we talk of the patients, there are patients who need the treatment urgently, like it may be a situation of oncofertility, poor ovarian reserve, or even maybe so many personal reasons, because it has started almost a year before, and now COVID is there, even in our country, more than about 9 months. So the patients cannot wait for unlimited period of time. So wait cannot be endless, and that is where it is a necessity now that we have to start offering treatment to the patient, and patients also are willing to get treated in this situation. Now, in that case, the first thing which is different is the so many reasons. Stress is because of the COVID itself. Stress is because of many people getting affected by COVID in your family, in your friends, acquaintances, doctors, nurses, and you read the newspaper and you get news of so many bad outcomes of COVID. And the stress adds up to the infertility factors as well, and stress adds up to the outcome problem of the IVF as well. So it can, we all know that stress and anxiety can change in sleeping patterns and mental health issues and hormonal imbalance, etc. Now it is very easy to say that we ask the patients not to keep stress, but it is not always that easy. What is said is difficult to practice. Use and distance yourself from the pandemic related news. A lot of bogus and wrong news also are coming, and continuously reading about those news definitely disturb a person. Use relaxation mindfulness apps to reduce anxiety, tension, and improve sleep. Collect information from reliable sources, very important. Interact with support groups, focus on fertility patients, and use the self-help books. So we need to reduce the stress, and we as a doctor or as a consultant can counsel the patients more, and that is where we can reduce the stress. And the stress was not only with the patients, the stress was there in the staff as well. People were, even the staff members were not so willing to come and work because they were also feeling that they might get infected, there can be problems, etc. Even today, after 9 months of COVID, the staff and others, even our own team members, do have some fear subconsciously in their minds about working in an hospital environment. So that stress is all around, plus the financial stress to the people because a lot of businesses are affected because of the COVID. So all this together, we need to take care. But in that case also, we have to start because the treatment has to start now. So if we want to start, how to start? Now, good practices for resumption of reproductive care is an important thing. And in that case, these are the very important things. Discussion and agreement on consent to start the treatment. This is very important because the patient also have so many questions in their mind as to what can happen, what cannot happen, whether the treatment will be completed or not. Just in case the treatment is not completed, what will be the financial implication? If they become pregnant, what will the implication on the pregnancy, etc. So many questions they may have. We need to adapt our ART services according to the new normal. Staff and patient trial. This is also very difficult because staff also feels that why so much of restriction, why they have to go for quarantine for exposure with positive patients, why they should not be allowed to go out in places where the risk is high. If they go to the places where the risk is high, we keep them away from the duty for a few days. Same thing for the patients. You ask so many questions to the patient that were you exposed to this, that, and all. They have to sign the documents. They don't like it, but that is something which compulsorily we have to do. Treatment cycle planning as per the new situation, access to advice and treatment, and code of conduct for staff and the patient. This has to be strictly followed. We have designed new consent forms only for COVID, that because tomorrow a patient can come to your hospital and say that just because he visited or she visited your hospital, she got COVID. No, you don't know that whether she really got COVID from your visit, hospital visit, from transportation, or from some other. So we have consent forms for every patient who visited, that there is a possibility that the other patients, some of them may be infected, your staff may be in incubation, and the hospital will be responsible for a COVID infection.
I think Dr. Bhavishi is out of the line. Devi, can you connect? Check that, please.
Has the connection gone somehow?
No, I think Dr. Bhavishi's connection gone.
He's back. He's back. Bhavishi is back now.
Yeah.
You have to unmute yourself, Dr. Bhavishi. You have to unmute Dr. Bhavishi. Dr. Bhavishi, we can't hear you. You have to unmute yourself.
Devi.
I have done. See,
Yeah.
I have done unmute,
Okay.
unmute for him.
Okay.
Correct.
Okay, good.
Okay. Can you see the slides as well?
Yes, we can see. Yeah.
Sorry about this because I'm out of Ahmedabad on a vacation, and that's why internet connection is a little bit disturbed. So we were talking about here that access points and limited workload, spacing of appointments, keeping distance between the patient sitting areas, preparing timetables, finishing the work in schedule, etc. also is important. And last but not the least, follow up the patient after the procedure is done. And most importantly, during the treatment cycle also, the ovarian stimulation and monitoring, minimum exposure of staff and patient, minimum number of visits for optimized number of blood tests, etc. And vaginal probe cleaning, your examination table cleaning, your office cleaning, your uh, fumigation, etc. has to be very frequent and regular. Oocyte retrieval, standard procedure we have to do. Only thing is that initially we thought that we have to freeze the embryos, don't do the transfers, but I will discuss that point also, that now that does not remain valid. And similarly, as I said, for embryo transfer and all OT procedures, limit the number of staff members in the office. Perform transfer only in the cases which are low symptomatic, otherwise it can be freeze all. And when we freeze again, the high security straws and vapor freezing if possible. Now, whether freeze all is a good choice for all of them or not is a big question. Initially, we were worried about the COVID effect and we did it, but now let's see the rationale. Now, if we see this rationale here, that we all know that the freeze all means if you don't do the fresh embryo transfer and only freeze and do the transfer, it gives us equal pregnancy chances, but sometimes even better pregnancy chances in situations where the ovarian response is higher. And the reason is very simple, that because of the controlled ovarian stimulation, there is a negative effect on the endometrial receptivity, which adversely affects the outcome. Whereas in FET, it is more physiological and may give a better outcome. Frozen cycles also have decreased risk of low birth weight, small for gestation, preterm delivery, and placenta previa, etc. But one of the most important things which we must need to keep in mind is that frozen cycles have given overweight babies, and we really don't know why it happens. It's epigenetic change or so. And there are some advantages in terms of obstetrics outcome as well. So who benefits from freeze all? We need to understand the patients with the risk of OHSS, obviously, patients at a higher risk, obviously, patients with expected poor uterine receptivity, hyper responders, and PGT patients. This is the very important slide. The high responders, if we see here, then the clinical pregnancy rate with fresh and frozen, if you see frozen is better. But intermediate responders and low responders, fresh cycles give better pregnancy chance and better live birth rate. So freeze all is not a standard policy to be practiced for all the patients or all the responders. It is good only for the patients who are hyper responders. Now, about the evidence of effect on the sperm, semen, follicle, we know that because SARS-CoV-2 affects the ACE2 receptors, and we know that ACE2 receptors may be present in many parts of the body, and that is where the risk of getting affected. I cannot go into the details of each and every parameter, but we know that sperm, in mature sperm, we don't see the ACE2 and the effect of SARS-CoV. Similarly, in semen, only spermatogonia it can affect. In follicle, it is present, but in oocytes and embryos, we don't see the SARS-CoV effect possibility. Blastocyst, again, there is a possibility. So that is where we have to be very careful while handling the gametes and freezing and storing of the gametes and the embryos. So we need to do the risk assessment at every point, as I said, right from clinic visit by the patients, treatment planning, and minimum clinic visit, avoid complication. This again is very important, that we in this era should try to practice even more safer ART than we usually practice, because the other hospitals are overburdened with COVID, number one. If a patient gets infected with COVID and has some complication or surgical procedure, then the risk is much more. So all these things in mind, we need to be more careful about avoiding any complications in our patients. That is also very important. So far as the pregnancy is concerned, early, late, or postpartum, the vertical transmission risk of COVID during the pregnancy, it is not proven. Neonates delivered by positive mothers have tested negative. No evidence of intrauterine infection. Vertical transmission in late pregnancy is lacking, and we are not sure what is the effect on early pregnancy. However, we have a few cases where we are not sure what actually has happened, but a possibility of vertical transmission is still unclear. So that is where we have to be careful, of course. And at the same time, these are, as I said, the rare but a possible transmission of vertical or horizontal transmission. And that is where we have to be careful that we don't increase any risk for our patient, for our staff, for ourselves, and for the future generation, which is likely to be born through the treatment which we are offering to our patients. Stay safe. Thank you so much for patient hearing.
Thank you
very
so
much,
much,
sir.
Doctor. Yes,
Okay.
Arindam.
No, thank you very much, sir. I am really moved by these few slides because these are important. I think
Yes.
each of the doctors who were present over here, you yourself are kind of an industry. So many population is actually depending on your expertise in your own establishment. So if you don't protect yourself, then it's a problem for us. And the other day, Dr. Mehta was been telling me that at least 23 of his colleagues has died. And that is a kind of a bad things that has happened. So nice, sir. I'm really moved by this.
Thank you so much.
So thank you so much, Dr. Dr. Bhaveshi, and very nice comments by Arindam. Lovely talk, and we all enjoyed it. Thank you so much, sir. And we'll have our queries in the end. I think you'll have a lot of queries for COVID. We'll talk about them in the end. And now I think you have already stopped your sharing of screen. I'll put on my screen now, and with I would like to invite Dr. Bandana for her next talk. Dr. Bandana, and if you look at her biodata, is actually mind-blowing. She has been awarded. She has been awarded for standing first in the final MBBS exam, best outgoing student of the year, and you can really in the medical college being the best outgoing student of the year is a very big thing. Then she has done her MSN OBG Gynae from RGUHS. She has done her fellowship in ART from there only. She has done multiple training. She's a member of ESRM, SR, FOXY, IFS. She has been faculty in the various lectures for SR, ACE, and ICOG. She has got multiple awards for excellence for her center in Hyderabad. Then she has been in the field of reproductive medicine since 2007. She is the CEO of Hegde Fertility Center, which came up in Hyderabad in 2009. And she's also a phenomenal teacher, has been running a 1-year full-time program for ART fellowship. I think it's a very big thing you're doing, ma'am, and we are so honored to have you with us. And Dr. Vandana is going to speak to us about adenomyosis. There's one subject we are all very scared of because there is an endpoint, and adenomyosis, in case we don't diagnose properly, will just linger on without any result. And that's one disease where we have to take a call very quickly, whether in case we go in for surrogacy. In fact, in many cases we advise surrogacy, or we want to do some sort of minimal surgeries. I'm sure that she's going to throw light on the subject well. So on behalf of the organizers, I invite the dais and take on the subject. Welcome, ma'am. So I'll stop sharing my presentation now, and I'll hand over the dais to Dr. Bandana.
Thank you, Dr. Talwar, for such a nice introduction. And I would also like to thank Biologically Company for giving me this session today. Mr. Jeevan, Mr. Tagore, and of course, Devi. And just start my session without... My screen visible?
Yes, ma'am.
So the topic today I'll be covering is adenomyosis with respect to optimizing the fertility outcome. So the first question would be, is there a link between adenomyosis and infertility? And we have seen that in the last 15 years, there has been an exponential rise in the number of publications with respect to adenomyosis, which was the in the 19th century. It was in 2005 that only 53 papers were there, and in the last several years, there are more than 200 publications towards adenomyosis in PubMed. So this renewed interest can definitely be attributed not only to the awareness, but also a significant improvement in the diagnosis of adenomyosis because of the advancing technology. So there are a lot of conflicting findings of the impact of adenomyosis on ART outcome, and it will always remain a source of controversy. So right now, other than endometriosis, we have this adenomyosis, which almost is like an enigma for us. So why are we seeing it more, especially in the fertility clinics, is mainly for two reasons. One, there's a trend of delayed childbearing. So we're getting women more than 35 years very commonly nowadays. And also there are recent developments in the high resolution transvaginal ultrasound scan and MRI. So in the wake of these technological progresses, the definition and the clinical burden associated with adenomyosis have dramatically changed over the last 20 years. So I'll not get into the details of pathogenesis because we all know that it is mainly the vagination of the endometrium into the myometrial space. And when these ectopic endometrial glands reach the myometrium, they're all hormonally sensitive, and they can cause a local reaction in the surrounding myometrium, resulting in the spiral vessel angiogenesis and the myometrial smooth muscle hyperplasia and hypertrophy. All of these lead to a thickening of the junctional zone, which is the most predominant feature of adenomyosis. And at the same time, it is associated with the diffuse enlargement of the uterus. So there are three important theories. The first one, what I told you, the invagination of the endometrium into the basalis along the intramyometrial lymphatics. The theory called autotraumatization, where there's a trauma to the endometrium, and the healing process also increases the progression of adenomyosis. So the other two theories are the embryologically displaced pluripotent malarial red nets and the displaced bone marrow stem cells, probably disseminated through the vasculature. The most common signs and symptoms are pain, menorrhagia, metrorrhagia, dysmenorrhea, and dyspareunia, but almost we know that 1/3 of them are asymptomatic. Coming to the prevalence, now this is a disease with the prevalence varying from almost 5% to 70%. I don't think any other gynec problem has this variation in prevalence. So this prevalence variation is mainly because of the method used for diagnosis. We have also know that adenomyosis is more common among the increased parity. So multiparous women are more commonly at risk for adenomyosis because of their association with previous DNC, cesareans, and also with there is association of adenomyosis with other high estrogen exposure conditions, especially the early menarche, the short menstrual cycles, and also with endometriosis and fibroids. So with there's one difference that we have seen, though all the studies in the past were related to multiparity. A very recently published prospective study in 2015, a study done among the patients who just came for a counseling on contraception when they went for a routine ultrasound scan. So because of the recent advances in scan, it's almost a 34% prevalence in nulliparous women who are in the age group between just 18 to 30 years. So this was the asymptomatic population where the prevalence was quite high actually. So now how do we diagnose adenomyosis? The initial studies were actually through the HSG, where actually on a HSG film, you can see there were small penetrations of endometrium, the irregularity of the endometrial border in the HSG. But then came the evolution of transabdominal ultrasound scan for adenomyosis diagnosis. But it is only when the MRI came, with the advent of MRI, that the diagnosis became more reliable. And they used quantitative and specific diagnostic criteria with the MRI. So hysteroscopy can also be one of the modalities for diagnosis, especially with small endometrial changes like hypervascularization, the strawberry pattern that we see routinely in hysteroscopy, the endometrial defects, and the hemorrhagic cysts. So the most important today would be the transvaginal ultrasound versus the MRI. So Reinhold et al. Who actually conducted a study where they compared both between the transvaginal ultrasound and the MRI, they concluded that they were almost the same. The sensitivity and the specificity of both were between 89 to 86%, and both were quite comparable. So based on its efficacy as well as the safety, the widespread availability, and the concordance rate with MRI, the transvaginal ultrasound scan should be considered the primary imaging modality for diagnosis of adenomyosis. So now when you look at these studies, though the satisfactory sensitivity and specificity results were all reported, but still the diagnosis remains difficult. It is still unclear and unreliable. Now, why is it so? Because if you have two people conducting these scans nowadays, one is a group of radiologists, the other are the gynecological ultrasonographers. And we all do not use always the same protocols. And so the results are very difficult to compare and to reproduce. And these interpretations are very highly operator dependent and probably even the machine dependent. So even the meta-analysis of imaging studies are quite questionable. So, and the other component is, when you have a lot of these studies coming out with their outcome on pregnancy with respect to fertility, you have these coexisting conditions now. You have endometriosis and fibroids, which are coexistent with adenomyosis. So it is very difficult to blame adenomyosis as the only reason for the pregnancy outcome. So if you look at the concordance rate between adenomyosis and fibroids, they're almost 50%, where adenomyosis is there, fibroid is there, where fibroid is there, adenomyosis is there. If you look at endometriosis, again, it's a 80% concordance. And when you have seen even in adenomyosis, there are different conditions like focal adenomyosis, diffuse adenomyosis, and all have a high reported common presence with endometriosis. And we also know that whenever we treat endometriosis and when we do a complete surgical excision in patients who come with chronic pelvic pain, in spite of a very effective surgical treatment, they do have persistent pain post-surgery. And this is especially common among patients who have a junctional zone involvement in MRI. So this is one image I would like to show where, because most of these, where you have comorbidities of fibroid, endometrioma, and adenomyosis, if you stick to only transvaginal ultrasound scan, this is an image where once you see a fibroid, these leiomyoma, they definitely cause an acoustic shadowing around, because of which you can see the adenomyoma can be missed, though it is just on the side of the leiomyoma. So these are cases where probably are the only situations where MRI would be recommended, because an MRI will definitely give you a better classification of between the leiomyoma and the adenomyoma when there are multiple comorbidities involved, when all three conditions are there together. So otherwise, both are actually very efficient in diagnosing. So coming to the MRI features, what are the important criteria? So Naftali et al. Described 7 criteria that are highly reproducible and sensitive to establish a diagnosis. And these 7 are the increased myometrial thickness, the asymmetry of the uterine walls, a heterogeneous ecotexture, irregular endometrium-myometrium interface, that is the endomyometrial junction, the intramyometrial cyst, the linear striations, and the presence of an adenomyoma. So even the presence of one criteria is sufficient for us to diagnose adenomyosis. So they have also found a very strong negative correlation with higher the number of criteria identified in patients, which is going to lower the success rate in IVF. So these features can be seen both in transvaginal ultrasound and even in MRI. So when these features were described and they were compared to the pregnancy outcome, they realized that a classification of these adenomyosis based on their histology would be the most important, because that is going to correlate for us with our clinical decision taking. So if you divide adenomyosis, there is an adenosis component, there is a meiosis component, and there's a myometrial vascularity. So the ultrasound findings actually, like the cystic striations, the myometrial cyst, and the echogenic striations actually concord with the adenomyome, that's the ectopic endometrial glands within the myometrium. When you look at the meiosis part, where there is hyperplasia and hypertrophy, they give rise to the ultrasound features of a thickened inner myometrium, the myometrial thickening, there's an enlarged globular uterus with a variational blind shadowing on scan. And the myometrial vascularity is seen in the form of increased vascularity and penetrating vessels. So all these findings give rise to a feature of myometrial heterogeneity on scan, which is also labeled as a cirrhosis of the uterus. So among these 2 important histological findings, or even on ultrasound scan and MRI, these 2 important features have been correlated with very poor reproductive outcome. One is the endomyometrial junction, that is the junctional zone thickness. The other is the focal adenomyosis of the outer myometrium. Now these 2 are totally different. Now EMJ comes under the diagnosis of adenomyosis. So there is an association between an increasingly thickened junctional zone and decreased implantation rate in IVF. Especially there is a very high first trimester miscarriage rate reported in women with adenomyosis, where there is a junctional zone involvement. Now what is the proposed mechanism for this? This is mainly because of the disturbed uterine peristalsis. There's an altered sperm transport. There's the effect of increased endometrial inflammation on the embryos and an altered hormonal environment in the uterus. In fact, a study has proven that when the average junctional zone thickness is more than 7 mm and the maximum junctional zone thickness is more than 10 mm, there has been no pregnancy after IVF in almost 96% of the cases. So this is the other component. Other than EMJ, you have the other component, which is adenomyosis being associated with a deep infiltrating type of endometriosis. Recently, the correlation between adenomyosis and endometriosis has gradually revealed that you encounter uterine adenomyosis without any junctional changes. And this has been labeled as the atypical adenomyosis, which often coexists with severe endometriosis and is localized at the myometrium without any aberrations of the subendometrial myometrium. And this FAOM is seen in 56% of the deep endometriosis patients. And these patients on laparoscopy were found to have higher the revised ASRM scores, suggesting that it probably is a marker of disease severity. So whenever you have an outer myometrium adenomyosis on MRI or transvaginal ultrasound, you should consider it as a red flag sign for the concomitant presence of deep endometriosis, and may therefore prompt further or a more detailed non-invasive investigation in these patients, because it's going to help us in our clinical decision taking. Now, as we know, the deep endometriosis association with atypical adenomyosis. So there are studies. Now, if you look at the evidence, how much of evidence is there supporting the poor outcome, reproductive outcome in adenomyosis? Let's start with endometriosis. So we know that whenever you compare endometriosis pregnancy or the live birth rate compared to any other indication for ART, whether it is male factor fertility or tubal factor fertility, this is a study done on only frozen embryo transfers. So you see the odds of a live birth was 76% higher in a male factor infertility compared to a proven endometriosis where it was surgically confirmed. And even with respect to tubal factor infertility, the odds of live birth was 26% higher in tubal factor, and both were significant. So now this is a study which was published in ASRM in 2015. So here they actually have screened for adenomyosis even before going for IVF. So these are the patients who were going for the first cycle of IVF where adenomyosis was screened, and they were pre-treated with long-term GnRH agonist even prior to their first cycle. That's for 2 months. And in such patients, they grouped the patients into 3 categories, where it was the group A was endometriosis alone, group B was endometriosis with adenomyosis, and group C was only adenomyosis. So if you compare the clinical pregnancy rate in endometriosis group was 32%, and with adenomyosis it was 19 to 20%, which was significant. And the miscarriage rate was highly significant with the in the adenomyosis group, where there was a significant p-value. So it's just not the pregnancy rate, but the miscarriage rate. And we all know that today the IVF success rates are moving from clinical pregnancy rate to ongoing pregnancy rate. From ongoing, we have moved to live birth rate today. So our entire goal is finally giving a healthy single child for the couple. So definitely our live birth rates matter more. So effective management of adenomyosis should be our goal. But there was a controversial study in October 2019. Now what they did was this is a prospective cohort study. So during the study itself, they've done a 3-dimensional ultrasound scan and identified the patients with adenomyosis, and they've put a single thawed euploid blastocyst transfer. So PGS has been done, and when you transfer a single euploid blastocyst, they have found that there is no difference with the clinical pregnancy rate or the live birth rate. They have found it is almost the same. Now, the only confounding factor in this study was that they have already identified patients with adenomyosis, and definitely when you have identified patients with adenomyosis, they have used a GnRH down regulation protocol in almost 16% of this patient population, the entire population. So once you have used the GnRH agonist down regulation protocol, we don't know whether that has improved the results with adenomyosis, and that is why this one study found that there was no difference in the outcome with euploid blast transfer. So this was a study in 2020. Now, after the IVF success rate, we definitely want to know what happens in the pregnancy. So there are many studies which have already proven that adenomyosis definitely has a poor pregnancy outcome. And this is a study done from Turkey, published just last month actually, where they've found that the preeclampsia risk is almost double. The small for gestational age is almost tripled. The preterm delivery rate is doubled, and the NICU admission is definitely more significant. And even the incidence of birth asphyxia is more. So this is a meta-analysis on the fertility, the pregnancy, and the neonatal outcome in patients with adenomyosis. And this is an article which is still in press. It is not published still. It is in the Reproductive Biomedicine online, where it has just come in September. So it's just 2 months back. And they have actually looked into 17 observational studies were included in this article. And they have concluded that adenomyosis was significantly associated with lower clinical pregnancy rate. And the lower clinical pregnancy rate was significantly more seen in patients who had a short down regulation. That means they also conclude telling that there may be a protective role of ultra long down regulation protocols, which probably needs a further evaluation. This is a study where now when we do studies, we definitely want to compare donated oocytes patients, because there we don't have the embryo quality as a confounding factor. We know the embryo quality is good. So when you transfer good quality embryos also in patients who go for oocyte donation, they have seen that when they grouped 51 patients, where 24 patients with adenomyosis and 27 without adenomyosis, definitely pregnancy rates were poorer in patients with adenomyosis. And even in this, when they categorized adenomyosis into focal and diffuse disease, diffuse had a poorer prognosis. And again, as I mentioned, the outer myometrium disease of the endometrium is an indicator of deep endometriosis, and you can see there's a significant decrease in the pregnancy rate in patients with outer myometrium involvement. And this study also definitely showed that not only the pregnancy rate, but even the miscarriage rate was high in the first trimester in patients with adenomyosis. So if you look at all these IVF outcome studies, there was a meta-analysis in 2017 which was published, and this showed that there was definitely a poorer outcome with respect to the IVF outcome with respect to poorer pregnancy rate. The live birth rate is decreased, and there's an increased miscarriage rate. And they also told that the pre-IVF treatment with GnRH agonist downregulation is beneficial in this. So if you look at that in this particular study, actually, they also had a concomitant where they have evaluated the spontaneous pregnancy rate in patients who underwent a surgical technique, where they underwent for adenomyomectomy, and after that they had spontaneous pregnancies, and actually the surgical outcome was quite good. When you actually look at the surgical management, it is not definitely a first treatment option, because we know the risk associated with adenoma surgery. And but with this surgery showing in a meta-analysis showing a good outcome with respect to spontaneous pregnancy and probably a decreased abortion rate also, when actually went and looked into these studies, they have also noticed that post-surgery majority of these patients were given hormonal suppression. So we don't know whether the outcome was related again to the hormonal suppression with especially the GnRH agonist. So surgical excision should be reserved probably only for patients with focal adenomyoma, which can be excised to improve the outcome. So most of these studies, even when you looked at the euploid blastocyst, you found improvement with GnRH agonist treatment, and even the meta-analysis concluded GnRH agonist has given better outcome. Even with surgery, you're combining it with GnRH agonist. So that means there is some impact of therapy on adenomyosis-related infertility. So evidence from comparative but non-randomized studies that down-regulation is improving pregnancy rate in FET cycles has been proven. So the potential mechanisms would be the reduced tissue inflammation, the angiogenesis, the reduced apoptotic index, the reducing the local hyperestrogenism thought to be related to the myometrial peristalsis. So all these probably could be actually relating to the endometrial receptivity. And also there are very recent reports telling that there's an extraordinary aromatase activity in the uterine adenomyosis and endometriotic tissue that is believed to be related to the local estrogen production. So with respect to aromatase activity, this is a study. This is just a case report which was published in 2007, actually, a very long time back, where they combined this GnRH analog with anastrozole. And this is an MRI picture showing the sagittal and the transverse section of the lesion of the adenomyoma uterus, which was actually quite significantly reduced with this combination by 60% volume reduction within 1.5 months of treatment with this combination. Now, even when they measured the CA125 value, which was 358, it dropped to 38 post 1.5 months of treatment. And with this study, it is difficult to conclude that the therapy improves fertility capacity, but it will not let the adenomyotic tissue actually become completely extinct. So it was after this reduction in size that it was a very long time, almost 10 years later, that this came out with respect to fertility outcome, where actually they've conducted a study where they've diagnosed adenomyosis prior by MRI imaging and the 3D ultrasound. And they were categorized 56 patients into two groups, where 27 patients received anastrozole 1 mg per day with goserelin 3.6 mg per month injection. And they compared this group with the Dynogest of 2 mg per day. And you can see a very significant difference in the pregnancy results. So the combined treatment is showing better results compared to Dynogest, with a higher reduction in symptoms and a higher pregnancy rate. So why anastrozole actually improved the pregnancy rate? Why are these combinations improving? And definitely these studies led to the studies on endometrial receptivity. So today we know that it is not histology. Histology is not the primary indicator of receptivity. And they also studied that in adenomyosis, the degree and the type of abnormal receptivity led to a range of reproductive problems, from complete implantation failure, that is infertility, to severely deficient implantation like miscarriage, and probably mild abnormal implantation and invasion like preeclampsia. So they have seen that there's a new concept came, which was with respect to the aromatase enzyme, especially where there's an evidence of the decreased estrogen metabolism in the utopic endometrium, and this is leading to a down-regulation of progesterone receptors, leading to a progesterone resistance. So they came to know that there is an epigenetic dysregulation of genes. That means the endometrium is not just a histology, there are implantation genes, and there's a molecular level changes happening with respect to receptivity. This is what estrogen does. When you have a local hyperestrogenism, it dysregulates a lot of genes with endometrium, where you can see there's an increase in the NK cells, the interleukin 6, and a decrease in the HOXA10 and 11, and a decrease in integrin expression, which all can modify the endometrial receptivity. So this new concept of progesterone resistance in adenomyosis has come to play, and these contribute new knowledge to the molecular processes in uterine pathology and implantation alterations of the endometrial regions. It is important for developing better diagnostics and new treatment modalities to reinforce the need for endometrial evaluation of patients with uterine disorders during IVF treatment to prevent implantation failure, and even alter how we manage unexplained infertility. So we don't even know whether are we dealing with unexplained infertility, and these could be the major reasons where we can modify the clinical treatment nowadays. And what is progesterone resistance now? It represents an organic and a systemic disruption of the progesterone and defines a defective and graded responsiveness to progesterone. So you have to understand that you cannot increase the progesterone dose to treat progesterone resistance because there is no receptors over there. And why is this happening? It's mainly an inflammatory pathway, seem to be pivotal to the phenomenon of progesterone resistance, and it is rapidly expanding field of study today. And this is a very important biomarker in the endometrium, that is the alpha V beta 3 biomarker, and it's an endpoint for progesterone resistance, and many studies have reported poor outcome where there is a lack of beta 3 integrin in the endometrium. And this type of defect in implantation was correctable by administration of letrozole, which will block the aromatase activity, restoring both the integrin expression and the fertility. So as we know that there are various endometrial receptivity studies like the ERA, this is a very new test for endometrial receptivity where you're actually doing the receptiva diagnostic test based on the overexpression of this endometrial BCL6. So this BCL6 has been shown that when it is high, high levels are indicative of poor reproductive outcome in IVF. And another suggests that, so how do you treat this? So GnRH agonist suppression can definitely improve the outcome by decreasing the BCL6. So we have seen many studies where you combine this aromatase inhibitor with GnRH agonist, the receptivity of endometrium is better in patients with adenomyosis and endometriosis, mainly with respect to the endometrial receptivity, irrespective of changes in the uterine volume. Okay, and now we know that new molecules have been released. So this is a publication. It's just 2 months back which has come, and this is the new molecule that has come, the linzagolix, which is a GnRH oral GnRH antag molecule. And this is a case report on actually the adenomyosis. So this is a very nice study where this is a girl who presented in. Girl who presented in 2017. Actually, you can see the volume of the myoma and MRI. It was almost 12 week size, and she presented with heavy menstrual bleeding, the pelvic pain, and she was desirous of future fertility. So in 2017, we all know the newest molecule at that time was the selective progesterone receptor modulator, that is a ulipristal acetate. And they used ulipristal acetate on her, but post that she developed aggravation of all the symptoms of adenomyosis. That's the figure B, which is showing the MRI report. And you can see the endometrial glands. Everything has increased, and the patient became more symptomatic, because of it the drug was stopped. So between 18 to 19, she didn't take any treatment, where the uterine volume in initial at 2017, which was 500, increased to 600, and then it reached total volume of 800, which is nearly 18 weeks uterus size. So in 2019, the new drug linzagolix was used on her, where she was put on 200 mg once a day for 3 months, and immediately within 3 months, the uterine volume decreased from 18 week size to critical size of about 10 weeks, and the volume changed from 800 to 290. So there was a significant decrease in the adenoma size, but we all know that that is not sufficient, because it is not the volume reduction and the symptomatic improvement that we are looking for as ART specialists, because again, ART is a challenging scenario in which we want multiple interventions, because our ultimate goal is not just elevation of the pathology, but also to improve the reproductive competence. So presently, GnRH agonists definitely may have some untapped potential, and future prospective studies are probably warranted with respect to reproductive outcome. Now, this is a very interesting study with respect to endometrial receptivity and unexplained recurrent implantation failure. So this is a study which was published just a few months back, just a year ago, and this was on recurrent implantation failure. And here the standard diagnosis of recurrent implantation failure was followed, where they saw that there was a 2 pregnancy loss with single blastocyst transfer and good quality blastocyst transfer. And in the third cycle, when they went for a good blast again, so third transfer cycle, they divide this. So they were have tested for all the APLA profile, thrombophilia screening, everything was done and ruled out. And they divided this group into 3 cycles where there was no other reason for failure. So the group 1 underwent the single blastocyst transfer with no change in protocol. The group 2 went for a protocol change in the presence of GnRH agonist alone. So they were given 2 months of GnRH agonist and then went for the transfer of single blast. And the group 3 went for the agonist with letrozole combination for 2 months followed by single blast transfer. And you can see the clinical pregnancy rate is quite drastically different in a patient already with RIF, where here the 40% clinical pregnancy rate in between the first group 1 and group 2. In the group 3, it has become 63%, which is clinically significant p-value, and even the live birth rate has increased significantly. So definitely the combination is working even in the recurrent implantation failure patients. So why should it change? So the concept of dual suppression before IVF has an appealing biological plausibility through the additional blockade of the aromatase receptors apparently expressed in the endometriotic implants as the utopic endometrium of women with endometriosis. So probably nowadays many of us are skipping laparoscopy because of the advent of IVF and ART treatment giving higher success rates. So probably we are missing the diagnosis of minimal and mild endometriosis, and even with ultrasound scan, many of us are probably not very well trained in diagnosing the adenomyosis. So probably these 2 conditions are getting solved with this dual suppression. So that is the hypothesis that they have put forward in the conclusion, that letrozole probably improved the integrin expression along and so improve the implantation and pregnancy rate. And the combination of letrozole and GnRH agonist should definitely be tried in patients with recurrent implantation failure, where you don't have a reason for their failure. So right now, with looking at all these studies, if you want to optimize the fertility outcome in adenomyosis, we need to look at optimizing mainly the diagnosis of adenomyosis, because if you can optimize the diagnosis, today you have got a lot of receptivity studies and you have got a lot of medical line management before opting for surrogacy and various other options, you can definitely optimize the treatment better. So this is an article which actually saw the role of transvaginal sonography and the MRI, and they gave the criteria for the diagnosis in MRI, where they divided these criteria based on the clinical response that we are seeing. So they actually did a classification where from A, B, C, D, E belong to the inner myometrium, the F, G, H, and I belong to the adenomyoma, and the J and K to the outer myometrium. So this is the MRI based classification, and today we can tell you that the transvaginal ultrasound images are as good as MRI, and you can almost see the histology of these pictures. So the pictures are so good that you're almost seeing it like a histology. So this is the ectopic endometrial glands, the myometrial cysts are quite clearly seen with the muscular hyperplasia and the hypertrophy and the vascularity. So it's like a histological diagnosis, and there are various ultrasound tricks where you can actually improve the diagnosis. And coming to the cine clips now. So what they tell is, you see this myometrial striations that we see, the venatial strips and all, you cannot actually see it in static images. You definitely need cine loops where you can actually take a sweep of the sagittal section and the transverse section, and these recorded slips can be analyzed later. And even the 3D pictures are so good nowadays that these can be saved and analyzed. They can be rotated, and you can see the entire 3D and the 4D pictures. Where what is the use of these recordings? Now the advent of artificial intelligence. So these AI approaches have actually come into place, where if you can give cine loops, they can actually go into the deep learning approaches. So even though adenomyosis is elusive, the artificial intelligence can be used to diagnose adenomyosis more effectively, because these images can be saved and the AI can be run in the background to diagnose better. And this is probably the best approach to design more objectively, scientifically, and probably a better classification will help us in analyzing our own studies in a better way. So coming to the conclusion, a standardized transvaginal ultrasound approach and a proper sonographer training are both essential for a correct diagnosis of myometrial disease. So starting from our adenomyosis staging system, the next goal will be to correlate the severity of adenomyosis as staged by TVS with the severity of clinical symptoms. So this will help us in choosing the best clinical and the individualized therapeutic approach. So actually there are a few potential important parameters which they have suggested to be included in the classification. So even when we do scan, we should concentrate on these few features. One is the affected area. Is it the inner myometrium or the outer myometrium? Where is it located, anterior or posterior or the fundus? What is the pattern? Is it diffuse or focal? What is the type? Is it a muscular type or is it a cystic type? And what is the entire volume that it has occupied the adenomyosis, expressed as 1/3, 2/3, or more than 2/3, or we can actually measure the volume in centimeters. So I can conclude by telling that Robert Edwards once said that endometrium is the last barrier to progress in ART, and that is what we have seen in these, that all the reported results today and the understanding of adenomyosis is greatly hampered by mainly the agreed upon terminology or the consensus on classification of the lesions. So a universally accepted classification system for adenomyosis is needed, and we would like to facilitate that it should be facilitated the design and interpretation of both the basic and the clinical research. So a good classification will actually provide a boost to all the studies in future. And right now the international FIGO group is on the way of preparing a document for classification. And as these technologies continue to improve with each passing year, 5 years from now, our clinical decisions will likely be based on totally different criteria. And probably more prospective studies using the pregnancy outcome endpoints are certain. And if we can do this, then definitely we can overcome this, whatever Dr. Robert Edwards said, we will overcome the last barrier to the ART success. So thank you.
Thank you very much, madam. I think Dr. over to Pankaj.
Thank you so much. It was a very wonderful presentation. Dr. Vandana, as always, you spoke about nearly everything under the sky about adenomyosis. And I was so happy to see that you have given the due regards to TVS ultrasound. Because a properly done 3D ultrasound to look at endometrial myometrial junction is much better than doing an MRI or CT scan that people keep ordering day in, day out. You have covered nearly all aspects of adenomyosis, and I'm sure that but you'll have a lot of queries also, because it's a very interesting topic. Thank you so much for being with us, and I think we'll take the queries in the end. So now I would like to share my screen back, and I would like to, ma'am, you'll have to stop sharing your screen, Dr. Vandana. So with the permission of the organizers, I would like to invite a very wonderful doctor, a very well-known clinician from Odisha. Her name is Dr. Kokila. Thank you so much for joining us, ma'am. And Dr. Kokila credentials are amazing. She's the co-founder and chief fertility consultant at Care Fertility. She is a clinical IVF and fetal head and fetal medicine trainer at a place called Embryo Education. She's totally in education, academics. I can see that besides doing her busy clinical practice. She has been a speaker in multiple national and international conferences. I've heard her many times. She has been faculty of many international workshops on clinical IVF. She's a co-editor of Joffrey Murphy Nif's newsletter that makes her a very academically inclined and a very profound and profuse writer. She is member of NIFS. In a few terms, she is member of multiple societies, bodies in our country, and she's got special interest in MIS and fetal medicine. The topic, ma'am, which you have to cover today is about endometrium, and I think it's a very amazing and challenging topic, and I think you're the right person to take on this particular talk. So with this background, I will stop my screen sharing, and I will invite you to come on the dais, and please start your presentation.
Hello, can you hear me, sir? Am I loud and clear?
Yes, ma'am.
Yes, we can hear you, ma'am.
Yeah. Can you see my screen?
Yes, we can. Please enlarge your screen. Go to.
Yeah, sure. Sure, sir. Thank you so much for the wonderful, kind introduction, sir. So it's been a pleasure for me to share the platform with you and Dr. Bhavishi and my other friend, Dr. Vandana. So at the outset, I would like to thank the organizers for making me a part of this program. And it has been a wonderful session so far, and I being the last speaker of the day. So I think I'll have to cut short and concise and make it more compact, so that we can finish off the program. So we are almost in the end, but still then I have taken enough pain to prepare the slides for about 25 to 30 minutes, I guess. So I will have to a little rush through the slides. So let me begin with my topic for today. It's about endometrium preparation to maximize the IVF success. So basically what we are worried is about to improve the success rate of IVF. So endometrial preparation becomes the integral part of an IVF. Just like a segmental approach, it has also become a part of a segment. Like, it forms the most important aspect in the preparation of endometrium, which is more responsible for the implantation and a success. So it's as good as establishing an ideal soil and seed relationship, as all of us know. And soil is something we're going to talk about is the endometrium, and seed is the embryos. And the result almost depends upon the soil and seed. So that's how a good endometrium and a good embryos can make a good pregnancy. So how an implantation takes place has always been a mystery. And implantation represents the remarkable synchronization between the development of the embryo and the differentiation of the endometrium. So as long as these events remain unexplained, improvement in the success of IVF modalities is likely to be slightly difficult, because all of us, we know that our success is maximum, the highest is roughly around 40%. So it becomes difficult for us unless we don't understand the pathology or the physiology of implantation. So coming to the basics of normal endometrium, what I believe, the once you understand the basics, that's how it helps you to make yourself strong in treating and knowing the underlying pathology. So let's know a little more about the normal endometrium. So we know that the innermost layer, what you can see in the picture, is the endometrial cavity, and surrounding that is the functional layer, surrounding that is the basal layer, and outer to that is the inner endometrium. So it is a highly regenerative tissue, just like our bone marrow, epidermis, and intestine, and it undergoes cyclical changes in the menstrual phase, where there's a shedding of the continuous shedding of the functional layer actually, and the basal ramen is supposed to remain intact. So once the basal layer is damaged, we know that there is a pathology, and the endometrium doesn't respond. It gives rise to poor endometrium, it gives rise to thin endometrium, it becomes very challenging. And the second phase is the proliferative phase, where the endometrial thickness is increased, but not to a significant change. But the significant change what occurs in the proliferative phase, secretory phase, is the glandular and the stromal changes under the influence of the estrogen. So here I'm showing you a normal picture of a menstrual cycle, which is around 28 to 30 days. And the alterations, what the receptive changes take place in the endometrium, is around the 16 to 20 days. So basically the changes take place in the second half is for the reception for the implantation, where the changes are seen histologically as there is a glandular mitosis, tortuosity of the glands, basal vacuolation, and the increase in the secretion, increase in the stromal edema, pseudostratification, and then leukocytic infiltration takes place. So this all has been studied under electron microscopy earlier, and that's how we know the histological changes. And that's how the advent of histological markers have come up. And in the second half of the pregnancy, it also shown that pin ports, which are the very important thing for implantation. And normally these changes occur between 19 to 21 days. So here is a picture showing basically how important is estrogen and progesterone for endometrial preparations. So basically we are going to talk about more about estrogen and progesterone and rest of the drugs or the medicines which are going to improve the receptivity. So let's know about a little about estrogen receptor and the progesterone receptors. To achieve successful implantation, the uterus has to undergo a structural and a functional remodeling, which is brought about by estrogen and progesterones. So these are the master hormones which mediate the changes. So basically the estrogen is progesterone receptor, they bind to the respective receptors, and that's how the action takes place. And the progesterone exists in two forms, like progesterone A and B, and estrogen receptors exist in receptors alpha and beta. So alpha is more important for the implantation to occur, and those who are lacking will end up in infertility. And this is another beautiful picture showing how the stages of implantation take place, where you can see a blastocyst getting attached to the endometrium. So depending on the location, the factors are present in the site, like in trophoblast and the epithelium, glands, and extracellular matrix, and descending stroma. Basically all the things in the endometrium, where they have a lot of factors which are responsible implantation, like the adhesion molecules in each and every site, and the integrins and the proteases, and a lot of plenty of things which are under constant research, because there are plenty, and the endometrium is always remains a mystery. So there are a lot of things happening there. So we need to have a little idea about the kind of integrins and the chemokines and the proteases involved for implantation. So for normal pregnancy to occur, we all know there has to be a fertilization between a sperm and oocyte and a good quality embryo. Then only the implantation take place, where it is supported by the progesterone. So it's basically, as I said, it's a crosstalk between the embryo and the endometrium, and it has to go well for the implantation. So in the window of implantation is the time where there's a maximum period of receptivity. So the embryo meets the uterus and it gets opposed, and then adhesion takes place and the invasion takes place into the endometrium. So roughly the window of implantation is between 19 to 24 days. So the target is always the implantation for the embryo transfer is roughly around these days, and according to the stages of the embryo. So in this window of implantation, you see increased mitotic activity, increase in nuclear DNA, and the cytoplasmic RNA synthesis, which prepare for the blastocyst implantation. So receptivity is basically about changing the expression of molecules, as the previous speaker talked about, the addition molecules involved. So there are additions, integrins of different types, and mucin 1 and mucin 6 and the selectins and immunoglobulins. They all form a receptive state of endometrium. So in the endometrium, the profile of expressed integrins varies according to the phase of the menstrual cycle. So the combined presence of certain integrins have been proposed as a means of distinguishing receptive endometrium from the non-receptive ones. So how do we normally evaluate the endometrium? Because diagnosis of receptivity has posed a challenge because of the lack of a particular perfect, accurate and non-invasive and an applicable test so far. There are a lot of evaluation receptors or the markers like histological, biochemical, molecular, and the ultrasound markers for receptivity, which have been proposed to improve the implantation rates. But all of us know the most commonly and favorably used is ultrasound marker, which is the endometrial thickness in terms of triple line, the thickness and the vascularity. And others are MRI and histoscopy, where you find some pathology, underlying pathology, or in a non-endometrial endometrium or a thin endometrium, here you go for histoscopy. So coming to the ultrasound evaluation, we all know that's the most easiest and non-invasive and reproducible evaluating method in terms of thickness, pattern, and endometrial and subendometrial flow. So coming to the thickness, basically it's all about how thin is thin and how thick is thick, and the appearance is typically has to be a trilaminar. And coming to thickness, as we said, so there are a lot of studies regarding saying above such a cutoff point is something which is called a good endometrium, and below which is called thin. So we roughly take it around 6 millimeter, which is considered to be the thinnest. And according to most of the studies done, they've shown that there has been negative predictive value of 100% less than 6 millimeter. But very occasional cases have been detected in 6 millimeter endometrium. There were some pregnancies showing that it is not only about the thickness, it is the receptivity at the molecular level which is responsible, and not only the thickness but the histological markers, which are also equally important. So the limitation of the ultrasound or lining thickness being is a poor positive predictive value. It doesn't predict the value at all. And coming to the vascularity, we know it's a zone 1 and zone 2, zone 3, where zone 3 is entirely covering all the 3 layers, vascular, highly vascular, which shows a better implantation rate. So endometrial preparation is basically based on the etiology of the endometrium, how the endometrium grows, and sex hormones, that is estrogen and progesterone based. So what basically they do is they improve the blood supply, or they increase the thickness, or they increase the estrogen levels by attacking to the receptors, or else you will have to correct the underlying pathology. So just a little while I was talking about how thin is a thin endometrium. Here I can give you some studies which say that less than 6 millimeter, well, they found no pregnancies, and group A, they said the thin endometrium is less than 7, and optimal is between group B is at 18 to 13, and group C is more than 13. So more than 14 is also not good, because even though there was an implantation, they found to be some miscarriage rates. So some of the causes for thin endometrium. So if we know the abnormal pathology, after knowing the normal things, if we know what goes wrong with the thin endometrium, what goes wrong when the endometrium doesn't grow is, like whenever there is a decreased estrogen exposure, that means there is a less exposure to estrogen, and there is a reduced blood flow, there's a damage to the basal endometrium, and there is an overexposure to testosterone, and there's a resistance for the estrogen what you're giving them. So these are all the things which cause a thin endometrium, and a new theory which says that there is a high oxygen tension in the basal layer. This could be the reasons for the thin endometrium. So targeting the causes for the endometrium, we can know how to prepare a good endometrium just by improving the blood supply, or increasing the thickness by giving them estrogen or supplementations, or by increasing the estrogen levels depending on the fixed and the normal dose, and otherwise correcting the underlying pathology. So estrogen preparation under the control of sex hormones is a key determinant for adequate blastocyst implantation. So it is a lot of studies have been quoted here, so which I don't want to go in detail. So they tell us how important are estrogen and progesterone for the proliferative phase as well as for the secretory phase. So endometrial preparation ERT is achieved through the administration of exogenous estrogens. And we know that when we administer estrogen, the best reproductive outcome is between 11 to 14 days, because if it goes lesser than 10 or less than 11, it does seem to have high abortion rates. And if you were given for more than 40 days, it was shown that there was a breakthrough bleeding. So ideally, it would have been around 11 to 40 days would be fine. And it has been proposed that the regulation of estrogen levels by administering different doses of estrogen is a key determinant of the duration of endometrial receptivity for embryo implantation. So coming to the different ways how we give estrogen therapy, it could be oral, transdermal, vaginal, and subcutaneous. Basically, it all depends on how convenient the patient can take and how patient friendly it is and how good it acts. So what does estrogen do? It increases the blood circulation even in the radial artery. So the dose may vary, the route may vary, the type may vary, and the regimen may vary from in different protocols. So logically, what one believes, or we believe, or we've been doing is a chronic low dose protocol where we start from the low dose around 2 milligram from the beginning, like day 1 to day 5, and constantly increase the dose after that from day 5 to day 8, make it 4 and then make it 6. So this is a more physiological form where people found that a lot of better results were obtained by using this more physiological form of using increment in the estrogen. Otherwise, you can directly start off with a high dose of 6 milligram from day 1 itself. And we can also use a transdermal patch in the form of 50 microgram for the first 3 days and make it 100 for the next 3 and 150 for the next 3. So basically, when exogenously we're administering estrogen either orally or transdermally from day 1 of the menstrual cycle, what happens is that is increasing either in an increasing dose or a constant dose from the beginning doesn't make a huge difference. So the starting dose of estradiol does not seem to be also as important. So when in a fixed date, so cancellation rate has been found to be around 7%. So a lot of studies in the cognitive evidence say that there was insufficient evidence to recommend one particular protocol over the other, like a constant or an increasing dose. Didn't make any difference in the pregnancy rate with respect to results in a fresh or a frozen embryo. And the current strategies to manage thin endometrium, even in women and health gynecology received, said that most patients show adequate endometrial response to estrogen by any methods. The simplest route preferred by the patient should be chosen. And if the endometrial thickness goal is not reached, alternative routes should be considered, as well as extending the length of the treatment, because we always believe that the length of the prolonged treatment of the estrogen days doesn't matter. It's the endometrium thickness which matters, from which they will be starting the endometrium. So now, what are the methods used in fresh or frozen protocols? So is it different in both fresh and protocols? Actually, the protocols is almost the same, but since we have started using frozen protocols because of the advent of cryopreservation, as Dr. Talwa said, is a huge stalwart in this aspect. There's a lot of thing happening, talking about frozen cycles in terms of success. So there has been found no much difference in the preparation. So in both ways, we can use a natural cycle, or we can use estrogen and progesterone. Depending on the base ovulatory function, we can add agonist or antagonist or no agonist. So endometrial preparation FET, with significant improvements in cryopreservation, as we said, number of frozen cycles have increased, and the advantage, as we already been talking about, saying that the cost effect or the success rate or the pregnancy outcome has been much fairer than FET, apart from few cases where you consider fresh transfers, like Dr. Vandana said, like few cases, especially in or Sir talked about it, like intermediate responders or low responders, where you can think of doing a fresh transfer. Majority of it have been a frozen cycle these days, and it has also helped us to come out of some complications like ovarian hyperstimulation and multifetal pregnancies. So the success of FET is closely linked to the synchronization between the endometrial maturation and the endometrial development. So such synchronization has been seen in a natural cycle after spontaneous ovulation, even within HRT, like hormonal therapy preparation with steroids. So currently, the most popular protocol what we all been using is endometrial preparation with the estrogen progesterone after pituitary downregulation with GnRH analogs in order to avoid the spontaneous ovulation. So now the talk came about using preparation of estrogen progesterone with agonist and no agonist, which I'll be talking about in another next 1 or 2 minutes. So first thing is how to optimize the success. So to optimize the success, there has to be optimum preparation, which depends on the protocols what you use and the progesterone support what you give and the receptive window of implantation which you're choosing for the embryo transfer. So the protocols are, it could be in a natural cycle, and as I said, it can be with or without estrogen, progesterone, with or without agonist, or using an ovulation induction protocols. So in a natural cycle, it has to, when you're doing this preparation, it has to be done in a proven natural cycle. The disadvantages being that then it needs a lot of frequent monitoring, and there's a premature luteinization, there is early increase of P levels, and there's a lot of islet surge which cannot be identified perfectly. So that gives a lot of discomfort, and it is one of the disadvantage where you're really preparing the endometrium. So here what we do is around 10 to 12th day, you start the ultrasound monitoring and keep on doing the monitoring by LH kits and then the progesterone levels. And once it is documented, after 3 to 5 days, you'll be thinking of doing a transfer. So as I said, there are some advantages that because the simplest and no medications used, and endogenous preparation of endometrium is done by the follicle which is growing, so you don't have to bother. But at the same time, the disadvantage is being that you cannot predict the ovulation in every patient, and even in a normal patient who's having a regular cycle, it can vary from even in the same patient as well. And the LH kits, what we've been using, it is more cumbersome. And so it was a modified natural cycle. Then it is a little better slightly, where you can use a regular ultrasound. And then when the follicle grows more than 17 millimeter, you're using an HCG and you're giving a little for support. And it is needs less monitoring and less burden. But basically, when all that is said and done, it's that there was no difference found in the outcome between the natural cycle and modified natural cycles. Coming to the programmed artificial cycle, what we've been talking about in the frozen cycles, it involves suppression of the natural cycles with or without agonist. As I said, agonist can be any form of agonist which can be used, and like nafrolene, buserelin, or the leuprolin, which has found no much difference in the using any drugs for that matter. So it requires exogenous estrogen for the proliferation of the endometrium while suppressing the dominant follicle, and we give progesterone replacement for the secretory changes to take place. So it can be used best in the irregular cycle, and it mimics endocrine exposure in natural cycle. So how do we administer? So estrogen administration can be started from day to day of the cycle, either, as we said, in an incremental dose or a fixed dose, and do an ultrasound. When the endometrium is reached about 8 millimeter, you add progesterone 400 milligram twice daily, and then transfer the embryos according to the stage of the embryo. So basically, what are the key points in artificial cycle? So you should remember that endometrial thickness should be more than 8 millimeter, which is triple line, and that endometrial development is unaffected by the length of the follicular phase. And however, the receptivity is best preserved between 12 to 19 days. The endometrium is unaffected by both the fixed or the incremental dosage. When you use an agonist protocol with endometrial preparation, the advantage is a little more, because we're using it in basically in a functional ovary, and exogenous steroids are used, and it simplifies the synchronization, more physiological, and decrease ultrasound monitoring and decrease cancellation rate, basically, which is the biggest advantage, where the disadvantage being that it is likely causing hypoestrogenism, as we all of us know, and there's a prolongation of the treatment, and there may be a cyst formation, and if they at all if they conceive, so it estrogen progesterone may have to be continued in the pregnancy in the first trimester. So what does the evidence say? So according to the Cochrane latest October 2020 says that we are uncertain whether the effect of agonist cycle compared to no agonist cycle in the outcome of pregnancy rate and miscarriage rate. So there is no much difference between using agonist or no agonist. So even in recent years, studies have reported successful use of estrogen progesterone with no previous suppression by agonist for the artificial preparation, and skipping agonist makes the procedure simpler and cheaper. So one thing you should remember when giving a no agonist is that very important to start estrogen in the early follicular phase, in 1 or 2. With this approach, we are suppressing the spontaneous ovulation, and if at all, if it started a little later, it may increase the incidence of LH surge and may cause the luteinization of the endometrium. So using hormonal therapy with or without GnRH, no differences absolutely, as I said, and which one is better. So even in natural cycle versus artificial cycles, there has been no much significant difference in the birth pregnancy rate or live birth rates. And only thing was, in a natural cycle, there were a lot of cancellation with very higher compared to the artificial cycle we used with GnRH. Apart from that, ovulation induction protocols where we use letrozole or letrozole with estrogen, CC with estrogen, or chronic low dose gonadotropins can also be used for the induction to make a good endometrium. So as we said, if you're using letrozole alone, we are starting from 2.5 to 5 milligram from day 3 to day 5, then TVS on day 8. And if at all they don't find a mature follicle, you're going to add on HMG. And then when the follicle grows for matures, and then you give a 10,000 HCG, and then ET is done after 3 days of ovulation, and you give a support with progesterone. Whereas in letrozole with E2, you're going to add estrogen from day 2 8 once the letrozole is over, 3 times daily for 3 days, and then monitoring with ultrasound from day 10 until the lining becomes 9 to 11, and then give HCG when the follicle becomes more than 17, and then give him the transfer on the day 2 day 3 depending on the stage, and then give a progesterone support. And a progesterone supplementation, if it is cycle, yes, just like estrogen, progesterone also has a great role to play. So it has been well documented in the pharmaceutical studies that absorption of progesterone in the endometrium is superior with the vaginal progesterone. It causes diffuse absorption, as we all of us know, compared to the intramuscular, where the higher serum levels are measured better with the injections. So traditionally, high serum levels were presumed to be better for effective outcomes. However, the 2 recent prospective studies again showed that increasing IM progesterone doses to achieve IM serum do not translate into improved outcomes. That means the intramuscular progesterone or the vaginal present doesn't make any difference, only that has to be adequate support. So, and also note that progesterone levels, when it's more than 20 nanogram per ml on the day of transfer of a single blastocyst, were associated with high ongoing low pregnancy rates. So natural cycle, actually, there's no need to add progesterone, you think, because there's a natural follicle growing. And in modified natural cycle, you give you give progesterone support. And in program cycles, we give progesterone 400 milligram orally or vaginally BD, or quinone gel 8% have also been really one. And a lot of studies comparing, saying that quinone gels were much better. People have done a lot of studies on that and said they were much better than the oral or the vaginal. And IM were also used around 100 milligram. So endometrial preparation frozen ET cycles, there is no difference between the even in sublingual or the parenteral use. So patient's preference and convenience as well as the cost should be considered when choosing the vaginal or the other preparations. Now, after talking about estrogen and progesterone, let's talk about some add-ons which is going to increase the live birth rate following the endometrial transfer, which may improve the thickness. Basically, we're worried about the thickness of the endometrium. And then we talked about extended estrogen therapy, and others are like pentoxifylline, which is going to improve the blood supply, and tocopherol, vitamin E, and L-arginine, sildenafil, and intrauterine GCSF, autologous stem cell therapy. Everything has been tried on earth, and everybody has enough of studies, and everybody's saying, talking good about it, but still the trials and everything are a little poor and inconsistent, so that we can make it a daily practice. So a lot of studies, as I've quoted here, have said that vitamin C or vitamin E or pentoxifylline or sildenafil, they could not improve the implantation process as thought earlier, and the process is not well established. So we cannot use left and right or daily, or make it a routine, or make it a protocol, like, it is a proven protocol and everybody must use, so that the endometrium is going to improve and it's going to be 100% success. So most of us have been using a large, it has got a better study saying that it did show a lot of improvement in increasing endometrial receptivity, where it is a nitroxin donor and improves the blood supply. And we use around 1.5 grams, used 4 times a day, and studies quote that there has been an improvement in the blood supply, in the uterine blood flow, as well as in the endometrial receptivity. Aspirin is something we've been talking for ages together, which has been started long ago, and everybody has been using aspirin in their preparations, and they found many of the studies have found some benefits. And at the same time, recent studies say that there does not been much benefit, but it all depends on how your practice goes and how actually you've been using your practice and how practically you've been getting the results. So aspirin is all about how you've been using, and it's not about the studies. It's basically studies, and the guidelines will give you an idea like how good it's going to be, but it's our job to put them into picture or put them into study and make a study on your patients and see how good it is going to benefit your patient. And that's how we can develop your own protocol. So what are the benefits of GCF these days on the ART outcome? There are meta-analysis case reports showing that when there was endometrium was not responding, GCFS injections have been used either subcutaneously or intrauterine. We've been given on day 8 or day 10 when the endometrium was not growing less than 7 millimeter. It was given on alternate days, and there was an improvement seen, like, gradually there was an improvement seen, and the receptivity was better. Coming to the endometrial scratch, this seems to be one of the favorite topics among a lot of the speakers. We must have heard in all the conferences we get to hear talking about endometrial scratch, and one person says that I've been doing in my practice for so many years, like 10 to 15 years, and it's become a routine. But when it started, like in 2007 in the first paper, and in 10, 12, 13, so on, so they did find some benefits, like when they declared it was a very good method to improve the receptivity. So basically, you are trying to find some alternative to improve the receptivity and give them a better success rate. So basically, what does a scratch do? It recruits new stem cells and creates new endometrium. So you're going to do endometrial scratch in the luteal phase around day 21, and you just take a strip, just rotate your movements gently, and that will supposed to induce inflammatory changes and improve the blood supply and the destabilization, and also induce some cytokines and growth factors. We've been talking about the receptivity are supposed to improve the implantation rate. But what does the recent conclusion say on this procedure? So it is absolutely, actually, they say that there is no role and time for this add-on treatment to stop, says many of them, like in the recent papers you can see. So actually it has no role in at least the first IVF patients or as a routine in your practice. So it has an indication only in a recurrent indication failure or to enhance the pregnancy rate. So it can be applied only in recurrent failures and not as a routine in a patient. And next thing what we're talking about is ERA. Everybody talks about ERA. For the few years back, it was hot topic of the discussion, like, ERA should be done for each and every person, and it gives you good results. Because yes, when the new study starts and the new procedure starts, it's full about controversies and conflicts. But somebody has to come to a conclusion, or the process or the conclusion or the decision making, it goes on, and there is no end for any study. So it is also called as a personal embryo transfer, where you can particularly select the day of embryo transfer to a particular patient, because we feel that the endometrium is dating wise, it is different in each and individual patients. So it is a microarray molecule analysis for hundreds of gene expressions, as we're talking about, there are more than 282 genes which are expressed in the endometrium, and we're not able to find out each and everything. So this study helps us to get one kind of a signature, like one kind of a picture, tells us that what kind of a gene expression is good and how good are they for the implantation. And there are a lot of studies. Again, it's a kind of like a biopsy procedure which involves just a sample of the endometrium and is taken for study, and the different signatures are like depending on the different samples, and the genes are come out. So it helps you in a diagnosing of a displaced window of receptivity, which is based on the RNA expression of transcriptomic signature found with endometrial cell sampling. So it's based on genetic analysis. Technology is then able to diagnose whether endometrium is receptive, pre-receptive, and post-receptive or non-receptive. So based on this study, you can know that when exactly you're going to transfer in the cycle, you're preparing cycle for the next month. So you can know that this cycle was the same in the next month, which day I'm going to do the embryo transfer. So basically, in FET cycles, there was about 25% difference in the biopsies and microarray procedures. Also, there was a displaced window. So similarly, using biopsies also showed that there was a displaced window. So the concept of personalized FET by adding 1 to 3 days progesterone and delaying the FET in women with demonstrated delayed endometrial development has shown some light. So ARAs definitely offered a hope to the patient who otherwise have no answers. And we are a little bit skeptic about this, using whether that the technology should be accepted because it is evolving still. And some believe it is a kind of a biopsy itself. So why should I do an ERA? Rather, I'll go for endometrial scratch or just doing a biopsy kind. So however, points to the lack of research and evidence-based medicine to prove this test accurately. So definitely it is indicated in recurrent implantation failure. Definitely it is an indication in cases like endometriosis and adenomyosis, where there is endometrial lag and there is endometrial preparation is much required for a better success, where you find less success rates in adenomyosis, as my co-speaker said just earlier. So it definitely has a place in endometriosis, and adenomyosis, and recurrent implantation failures. So what are the empirical use we've been doing is the heparin, corticosteroids, and immunoglobulins, and erythroid infusion. So basically in our practice, what I believe in my practice for the past 10 years, that we've been using heparin as regularly, and then corticosteroids and immunoglobulins, in particular recurrent implantation failures or a case of endometriosis, and very selective cases, intralipid infusion in very few cases. But large confirmatory studies are necessary to recommend them for regular use, so we cannot use them regularly. Coming to the regenerative medicine, when we are every day we're talking about PRP and stem cell therapy, a lot of things happening, a lot of people giving trainings, and a lot of people are using it on their patient just to see if there's going to work or not. So the ideal candidates are basically those who have persistent thin endometrium with repeated implantation failures, and a treated case of tuberculosis with the thin endometrium, and you find Asherman syndrome where there are thin endometrium not responding to the treatment. So these are the patients what we can consider for using them for PRP installation and stem cell therapy. So there are some few studies again saying that they're beneficial and non-beneficial. So arguments are always there. So one of them found that when 1 ml of PRP was injected, where autologous blood is taken, and just like IUI preparation, we prepare the semen, we prepare the blood, autologous blood, and then take 1 ml of it and then inject into the endometrium. It has shown that 1 to 2 doses has made a little difference in increasing by 1 millimeter. At the same time, another person has said that no, it was not at all beneficial and it didn't give him much success. So everybody has their own stories regarding this. And some case studies regarding the stem cells, we have seen our own Chaitanya, Sir, and Sonal Panchal and other studies quoted here that in some of the patients where, especially in the Asherman syndrome, and the stem cell therapy did help them in improving the success rate. So this is something called embryo culture injections. What like we believe that there is some communication gap or something between the embryo and the endometrium. So they tried using the embryo culture, what we use when we do preparing the embryos. So the supernatant was taken and it was injected to see if there was any difference. So what does the Cochrane data say? So it says that they were uncertain whether the routine use of endometrial injection of embryo culture supernatant before transfer did have any positive effect in women undergoing anything. So again, it was uncertain, and that's the final conclusion about endometrial culture. So coming to the conclusion, it is not possible to recommend one endometrial preparation method over the other. Future RCTs should not only address the pregnancy rate, but also should consider the convenience and the cost efficiency too. So no significant advantage of one specific approach to prepare the endometrium for FET in terms of pregnancy rate or live birth rates. Choice for natural artificial should be based on some factors like number of canceled cycles, what you've done, and number of hospital visits, the plan, and then the possible adverse effects, and the hospital and what the logistic setup you have, and the patient and doctor preference. But unfortunately and sadly, there are no publications to address these factors. So unraveling the mystery of the mechanism controlling the receptivity of human endometrium remains an exciting challenge. Despite enormous research in the field of human embryo implantation, the ideal marker of receptivity remains indefinable. Lack of accuracy, predictive value, and invasive nature of the biochemical and histological markers of receptivity limit their clinical applicability too. So our job is to go on studying, do on research more to optimize your success, because you need to have an optimal preparation if you want to give a better success rate in your practice. Thank you so much for your patience hearing, and I thank all the organizers for giving me this opportunity.
Thank you very much, madam. Thank you very much. Just for your knowledge, Dr. Talwar has left because of some emergencies. And I think we are also at the end of 2 hours of discussions. And today, I think you are also busy and everyone is busy. So we will just push off if there is any questions fast. And then we will finish this meeting, because you all 4 are very, very busy guys. So I can understand that.
Yeah.
Just I will share one of my product screen so that we can keep a kind of a brand reminder for our purpose. So, Devi, there is any questions?
I'm waiting for the questions, sir.
We'll wait for 5 minutes, then I will close this meeting if required.
Please post the questions in chat.
This is a subject, so I think the questions would be rather, and this is our first time that we are over here.
Devi, I remember Dr. Madhu Singh had raised her hand in the beginning of the session.
Yeah.
And check with her.
Yes, sir.
Dr. Bhavishi has come back.
Yeah. So there is a question from Mr. Adi Das. When adenomyomectomy should be advised?
Dr. Hegre?
I'll take the question, yeah. See, for adenomyomectomy, one is that you have to prove that adenomyomectomy is the only reason for the failure of the IVF. So that's the primary thing, where you need to prove that the embryo that was transferred actually of good quality with good endometrial thickness, and it should be a focal adenomyoma, which is probably along with a junctional zone involvement. If that is proven that if it is the only reason probably for failure, then you can go ahead with the surgery. Now, coming to the surgery, there are a lot of techniques that have been described with respect to the surgery. The principles are similar like myomectomy, only the operator who's doing the surgery should be quite well experienced, because the only risk is for uterine rupture, but again, that can be taken care of by using the correct principles in surgery. So we have also done a few cases of adenomyomectomy. So definitely, if you can actually do it, there are even microsurgical techniques where you do for where you the problem is that between the adenomyoma and the myometrium, you should ensure that the chunk of the myometrium should not be removed, because the more you remove the myoma, the surrounding myometrium, that is going to create a more of a defective space over there, and the risk for rupture is there in pregnancy. But if you can take care of that, you can definitely go ahead with adenomyomectomy, where it's a proven cause, where the surgery is definitely recommended.
One more question, ma'am. For FET, how many days we can give estrogen, minimum and maximum limits?
Well, I think I can take this question.
Yeah, please.
Yeah. So basically, when you start preparing for endometrium, as I said, it can be a constant dose. Like if we start from 2 milligram in incremental for the first few days, 2 milligram, and the next 5 days. So otherwise, you can just a constant dose of 2 milligram thrice daily. It becomes up to 6 milligram. The maximum dose we start is 8 milligram in the worst cases. So 2 milligram thrice daily becomes 6 milligram per day. And I'm sure that it will respond by 5 days, 7 days. You know that it has responded. It has grown beyond 7 millimeter. It's quite optimal and adequate. And along with the thickness, you're going to see the vascularity. As I said, it is in the zone 3 or not. So it's not only thickness, it's the vascularity which matters. And then during the preparation, the exact number of days doesn't matter. As I said, the proliferative phase, it can vary from 10, above 10, but minimum should be 10. So above 10 to 12 days, so as long as 15 days, but as long as the endometrium grows. But when a certain point of time, when after giving the estrogen for 10 days, if it is not growing to go beyond your expected like 7, even after 10 days of estrogen of high dose, for example, so that there is no meaning that for continuing the progesterone preparation for the next few days, because by 10 days with the high dose, if it's not responding, is definitely an endometrium which is not good, or it is a thin endometrium which is not going to respond. So rather in those cases, you're going to try out with using like what we've been talking about, like GCSF or PRP, and then look for endometrium thickness. So otherwise there is no maximum dose, like maximum 8 milligram to 12 milligram maximum what we've been used, but the patient will complain of chest pain or the breast pain or some kind of not feeling well kind. So you should be careful when you increase the dose or beyond the limited dose. I think that's what the answer is for the question.
Okay. Then one more question, again from Mr. Adidas. How many months of GnRH agonist suppression should be given for FET in adenomyosis cases?
See, with respect to suppression of adenomyosis, the longer is the best. So what is the problem with GnRH agonist? See, the longer you give, you're facing side effects, and these side effects are quite severe, and the most severe among them is definitely the more bone mineral density. And this definitely starts decreasing significantly when you give it beyond 6 months. So though we prefer long durations, where even there are studies where they've measured the adenomyoma, the entire volume of the uterus, regressing on MRI even after 2 years. So it may take sometimes very long time, but we cannot give GnRH analog for more than 6 months presently. So these studies where they've even compared with 3 months suppression, they tell it is not sufficient. So it is because of these problems that they're going for alternative modalities of treatment, whether it is the oral GnRH antag or the aromatase inhibitor. So these probably in combination are going to help you better. Now, how will you monitor how effective it is? See, the effectiveness of treatment of your GnRH agonist or any other medicine that you're using is probably on ultrasound scan. So you'll probably have to track a scan features of all the components of adenomyosis, all the criteria that you have used to diagnose. And you should look at the improvement of these criteria on the subsequent scans. So this will give you an indication of probably when you can take her up for a transfer. And the other probably the chemical marker is your CA125. So if she has initial values high, you can also go for monitoring of CA125 to see the improvement. The problem is you cannot give it for longer, though we would like to give it longer.
Again, one more question from Mr. Adidas. Role of Dynogest versus GnRH agonist prior to FET in adenomyosis.
Right now, Dynogest is probably not showing as good results as aromatase inhibitor, but we again in our practice, we routinely use Dynogest because it is very, very well tolerated by patients compared to GnRH agonist. So sometimes we start with 1 or 2 depot injections, and because we don't want to give it longer, we convert to Dynogest. So these Dynogest, I have seen where personally I've given it for even 6 months, 1 year, and we have seen improvement in clinical symptoms and in the patient profile for transfers also. I've used for more than 1 year and 2 years also. I've put patients on Dynogest. So I think it is very safe to put the patients on Dynogest. Agonist use, we are definitely decreasing. We do not personally use in our center for more than 3 months. We switch over to the Dynogest.
I think we have completed the questions. Yes. Right. So once again, thank you all our esteemed panelists for their deep insights on reproductive health. So today's panel discussion has certainly impressed upon all those vital aspects of infertility, and I'm sure it has enlightened our participants today. So I would like to hand over the session to Mr. Tagore. So over to you, sir. Please close the session with your closing remarks. Sir, unmute yourself. I think one more question we can see, ma'am. How long letrozole should be given?
See, the present studies with letrozole have been very recent, and right now they've used it in combination with GnRH agonist, and most of these studies are just for short term. So probably 2 to 3 months is the duration which would be the recommended treatment right now. Because anyway, we are using it only to prepare the endometrium for frozen transfers. So 2 to 3 months of suppression should be enough in combination with an agonist. Yeah.
One more question from Padma Priya, ma'am. Dydrogesterone is better or natural micronized best for luteal phase support? Kukla ma'am, would you like to address?
Yeah, sure. Basically, it's luteal for support. It's been always progesterone has been using, but in very particular cases like endometriosis, adenomyosis, and recurrent implantation failures and immunological causes, so you can add on with dihydrogesterone. But otherwise, majority of the cases, if they're not having any of these reasons, so progesterone support, adequate progesterone would be sufficient.
Okay. So this question is from me, ma'am. So if we ask, like, what do you, which molecule will you prefer, like dihydrogesterone,
Micronized natural progesterone,
hydroxyprogesterone, or micronized progesterone?
micronized natural progesterone.
So is there any particular reason, ma'am?
As I said, the immunological things are taken care by dihydrogesterone, so it becomes a separate entity, because earlier the molecule or the height which was associated with that, like, dihydrogesterone should be used, and every prescription would have only dihydrogesterone, not a progesterone, because some believe that that is the only thing, and they've been using in practice for more than 10 years. So they believe that dihydrogesterone is the best. But people who have been using progesterone for many years also believe that progesterone, that too micronized progesterone, a lot of studies and your own success and with your own patients, it's going to be much beneficial and much economical compared to the dihydrogesterone, where you just improve the molecule, which is more costlier. That's why we don't have many companies having dihydrogesterone, hardly one or two companies, as you may be knowing. But whereas progesterone is something which is easily available, and micronized progesterone or IM intramuscular progesterones and vaginal applications have been more convenient and more efficacious, more efficacious compared to dihydrogesterone. So definitely, as I said, depending upon the cases, like the other kind of cases where the recurrent implantation failures and endometriosis and endometriosis, you can consider using dihydrogesterone along with them. But otherwise, micronized progesterone is more than enough for a natural support.
Okay. Fine. So one more question from Padma Priya, ma'am, Miss Padma Priya. Ulipristal estate can be used for adenomyosis.
See, presently in India, ulipristal acetate has been banned by the Drug Control Authority, and it has been also banned in European Union because of the liver toxicity that many cases have been reported. And this liver toxicity is sometimes very unpredictable. Like, you start the drug and it is seen, so you cannot predict. So presently, ulipristal acetate has been banned, so we cannot use it for any purpose, whether it is for fibroid or for adenomyosis. And the results also have
Role of L-arginine in improving poor embryo transfer.
Poor ET, it is endometrium, right?
Okay,
So L-arginine definitely has a proven role in improving the endometrial rather thickness. You can improve the blood supply because that gives more vascularity in the endometrium, as well as improves the blood supply in the uterine blood flow, as I said. And if it's used at around 1.5 grams, so definitely it is become a part of a practice, and it is definitely has improved the success, or it has become a routine rather, you can say, because basically what we're talking about vascularity is it has to improve grade 3 vascularity, so we use L-arginine routinely.
Letrozole or anastrozole, which is better?
See, finally, both the drugs are the same. It doesn't matter what you choose. So it depends upon your availability and your convenience. It's left to the doctor's choice. As such, both the drugs are the same.
Okay. I think we have completed the questions. Yes, ma'am, we have completed these questions. So Himanshu sir just joined. I think so there is some problem, network problem. Jivan sir, would you like to close the session with your remarks?
Yeah. So, I mean, since there are no more questions, I would personally like to thank Dr. Talwar, Dr. Bavishi, Dr. Hegde, Dr. Das for a really intense and detailed talk on each of the expert subjects. And I could see a number of questions from the doctors, and which were very ably answered. Frankly, with such luminaries in the panel, I hope everybody could find some meaning in investing their time in this session. Personal thanks to all the faculty for taking their time out. Any errors from our side, I hope you will all excuse us, because for us it was the first time that we were, trying to get involved with the infertility segment and all the specialists here. From biologically side, I can assure you that we will continue to expand our interest in all the academic activities related to the infertility segment, and we will continue to work hard to launch more products and commit ourselves to the cause of helping childless couples to get success and be part of your contribution in that. With that, I would like to say thank you very much and good evening. And last words
Thank you,
from
dear sirs. Thank you very much, all the doctors. Thank you very much for giving us 2 hours of your important time to us. At this moment, we are having enoxatil. We are already supplying to the IVF market, and we will be creating an ecosystem for all these kind of niche market players to discuss amongst themselves in this pandemic time and even afterwards also. In very soon, by the month of Jan or Feb, we are planning to come with Leuprolane and Sertrolix as our initial offerings to you. We have big plans. I need all of the doctors who has been appeared over here to support us. What are the best way, both not only in prescription, but also in your ideas or the ways that we can improve ourselves. So thank you very much. Wish you a very good night and happy Christmas also.
Thank you. Thank you for inviting.
Thank you. Thank you. Thank you very much.
Yeah.
Thank you.